I'm Sharon Prince, consultant maxillofacial surgeon. I work at both Norfolk and Norwich and James Paget Hospital. That's my technical support just leaving, which is a bit unfortunate, really. So I wanted to talk today about OPT radiographs, so-called OPG radiographs, because I think they're not taken as often as they might be as a preliminary investigation for upper neck swellings by colleagues in the nose and throat department. And really, I just want to talk you through them, explain what information we can get from them, how we take them, which is crucially important to the patients, but also what are the limitations, when to request it, and give you a few pictures to illustrate some of the points I'm making. So we'll crack on with that. So this is a standard issue OPT radiograph. And as you can see, lovely views, teeth, fillings, an extraction socket, the mandible. If you look really carefully at it though, you'll see that bits of it are in much sharper focus than others. And if you look at the roots of the lower incisors, you could be forgiven for thinking there might be pathology there, when what we're actually seeing is it just being out of the focal trough. So this radiograph represents a single tomographic cut through the mandible set to average values. So bits of it are sharply in focus, and it's really good at looking at the molar region, but bits of it, such as the midline, are not in quite such clear focus, but it does provide a really good overview. And as you can see a little bit from the anatomy, we can see the whole of the mandible, coronoid processes, condyles, but also the maxillary sinus, floor of the nose. You can see the base of the zygomatic arch here, even a little bit of external auditory canal, cervical spine. There's lots that we can see on an OPT radiograph. Now, it's used a lot by dentists, and dentists number teeth. We number teeth because we can pass information across to each other really readily. And we number them in all 4 quadrants. So 1 and 2 are the incisors, the central and the lateral incisor. 3 is the canine. 4 and 5 are the premolars. 6, 7, and 8 are the molar teeth, with 8 being the wisdom teeth. For deciduous teeth, the nomenclature is a bit different, and we use the letters A to E for the baby teeth. So this is an OPT radiograph of someone with a really nice, healthy mouth, no fillings. You can see the wisdom teeth at the back. 3 are probably unerupted or partially erupted, and 1 erupted. You can see all the things I've spoken to you about already, such as this midline area of blurring. You lose the definition around the roots of the incisor teeth, but really quite a nice, crisp view involving the molar teeth and their roots. You can see the pulp canals and pulp chambers of the molar teeth quite clearly, and you can also see this rather bright cap, which is the enamel cap, and strong surface layer of teeth. So it's really good at picking up tooth-related pathology, and I put this slide in because there's quite a lot of tooth-related pathology here, which is just worthy of a look. But to bring to your attention the fact that the upper wisdom teeth, when they're unerupted, often sit quite close to the maxillary antrum. So if we look at this lower right second molar tooth, you can see a dark area around it which represents bone loss and probably chronic sepsis. Got a really smooth outline, likely to be benign. Tooth has been root filled previously. And if you look at the roots of the tooth, the distal root, it has got quite a smooth outline, but you can see little bits out of the surface of this tooth where it's undergoing a resorptive process secondary to infection. You can see other teeth with root fillings, and this one's done rather well, done rather better than this one has. And you can see nice healthy bone all around the tooth that's been root filled. You can see the antrum dipping down very close to this second molar tooth, and the shadow of what might be an antral polyp. Now, there may be a deep periodontal pocket going from the mesial aspect of that tooth and causing this inflammatory response in the maxillary antrum, it's difficult to know, but they're all things that we can see on an OPT radiograph. So the other thing we can see is the inferior dental canal. As you can remember from anatomy, that the canal enters the mandible or starts at the lingula on the inner aspect of the ascending ramus of the mandible. The canal and inferior dental nerve and vessels run through the mandible and exit at the mental foramen, where they supply sensation to the lower lip and chin point. You can see here that the inferior dental canal is quite close to the roots of molar teeth, so numbness at the time of dental sepsis is not that uncommon, and particularly if you get an osteomyelitic process going on or osteoradionecrosis, it's really not uncommon to get lip numbness. Clearly, if you have a fracture in this area from the angle to the premolar, you can also get numbness as a result of traction on the nerve. I've put this in as an edentulous mandible. Teeth are gone, basal bone here, nothing very remarkable about that. These are extraction sockets. So this patient's had a dental clearance, and if you see someone with sepsis who's had a recent clearance, look in the sockets to make sure that they are clear, that there aren't any pieces of residual root left behind which can cause infection. So indications for taking an OPT are acute facial and cervical swellings. And I personally feel an OPT should be the first radiograph of choice when a patient presents with an upper neck swelling, because the most common cause of upper neck swelling is tooth-related sepsis. Chronic facial swellings, such as fibrous dysplasia, this can also give some really useful information, and facial trauma, which I've mentioned already. We also always take an OPT radiograph in the workup for head and neck cancer. For a couple of reasons, really. One, to assess the dental state of the patient, such that if they require radiotherapy, we know that they're not going to need, soon after that, numerous extractions which could cause complications. But the other reason is you can sometimes see evidence of bone resorption on an OPT. So we use it as a primary investigation for oral facial pain. We can sometimes see arthritic changes in the temporomandibular joints, and a lot of dental bits and pieces such as orthodontics, implant placement, wisdom teeth, TMJs, etc. So a lot of dental practices have these machines. They're really quite small and very easy to use. You can see the patient positioned in this one. If I move on, you can see a bit more detail. So patients typically stand up in the machine and the gantry rotates around them. They can hold on here to these hand supports. They generally have a prop between their teeth to support the teeth so we can see more tooth detail. Forehead's resting here, and chin is also nestled in a little chin cap. So they're reasonably easy to position. The gantry rotates around the patient, and the acquisition time is about 20 seconds. So as you can see from this, you need to get this clear of the shoulders in order for it to work. So severe kyphosis can be a limitation. Similarly, a patient in a bed who can't get to stand up or sit up, again, that can be a problem too. And some wheelchairs where you can't drop the back of the wheelchair aren't suitable for taking an OPT. And patient cooperation. So it's limited how much cooperation we need for this radiograph, and most patients, including children, seem to manage it quite readily. So if we look at strengths and weaknesses, as we've said already, gives a really good overview of the mandible, lower maxilla, including the maxillary antrum. When patients get dental-related sepsis, they often have severe trismus, restriction of mouth opening, And these radiographs can be taken in a patient with trismus. Some patients have a gag reflex, which precludes putting anything in the mouth. And again, they tolerate this radiograph. Children and phobic patients generally do quite well too. And it's quite an easy view to use to explain pathology to the patient. So the weaknesses in all this are, as we've said already, the poor detail in the midline. We can sometimes see artifact through not removing dentures, glasses, etc. The earrings, they should all have their earrings removed. There can be positional problems. We see a pharyngeal air shadow, which again can be mistaken for a fracture, and patient positioning is quite important. With regard to mandibular trauma, we would need a second view in order to be sure that there weren't fractures anywhere other than what we'd seen on the OPT, and we generally do a PA mandible alongside an OPT. So as we've said already, there is a focal trough, and that's maximal in the molar region of the mandible, the body of the mandible, and we get a degree of magnification. Now, reporting is quite important, and most radiographs we take, if you take an X-ray of someone's broken arm, you get a report back quite nicely. In a lot of trusts, because the maxillofacial departments are the main ones to request OPTs, there isn't routine reporting. So if you get a radiograph back unreported, I would suggest you either request a report or you ask one of your maxillofacial colleagues to look over it and enter in the patient notes a report that can be quite useful, because medical legally, these views have to be taken by someone who can interpret them correctly. So the dosage in order to take an OPT is, I'm told, 0.014 millisieverts compared to a chest X-ray of 0.02. Someone once told me that it was the same dosage as the dosage of cosmic rays if you fly one way to Spain. So to put it in context, that's quite a low dose. So we can have positional problems, and I think there have been a couple of problems with this rather poor view. When you look at it, you get the impression of asymmetry, and you get the impression of a deep ascending ramus on the right and a rather narrow one on the left. If you look up at the condyles, you can see the condylar positioning is incorrect. One condyle is sitting nicely in the fossa, the other is forward, so there's asymmetry in the patient positioning here. And again, we can see bad teeth, we can see evidence of infection underneath teeth, bone loss due to periodontal disease. This is a slightly more chaotic view, which is of a young person. And I show you this because this is a mixed dentition phase, and you can see the developing molar teeth, calcifying and developing within the tooth follicles. You can see deciduous teeth, erupted permanent teeth, and the developing canine and premolar teeth. So yes, it does look a little bit like a mouthful of teeth. As these teeth develop within the follicle will fuse to the overlying oral mucosa and the teeth erupt. And I'll come on to that a bit later because that's quite important in terms of tooth-related pathology. So teeth are sometimes out of position, and I've just added this one, which shows the wisdom teeth that haven't come in, not properly developed yet. Second premolar tooth, again, trying to push the baby tooth out, but this rather rogue canine tooth, which is sitting in the chin point. And any tooth which erupts at the end of a series of teeth is more likely to be out of position. So we get the canine teeth, which are sometimes in slightly strange positions, and commonly the wisdom teeth also. So quite a good quality OPT radiograph here, showing horizontally impacted wisdom teeth. There has been a fracture down through the angle of the mandible, and if you look carefully, you can just see a lump of callus, so the healing process is taking place. What I want to do though is bring to your attention this dark shadow. So this is the lower left second molar tooth. You can see quite clearly this enamel cap of hard material that protects the tooth, but underneath it in the dentine, there's a dark shadow. Now this is dental decay, demineralization of the tooth as a result of Carotid bacteria, and not being able to clean the gap adequately between the wisdom tooth and the second molar. Now you can see this dark shadow is rapidly approaching the pulp chamber in the middle of the tooth. As it gets closer, bacteria will go along the dental tubules. The process will be set up in the pulp, and at that stage the patient gets raging toothache, really throbbing pain that's enough to keep you awake at night. Once the nerve dies, that pain can stop, and the pain can be asymptomatic for a period of time. But because you've got necrotic tissue in the pulp chamber, you start to get an inflammatory response and can get infection at the tip of the roots of the tooth, and that can show as a dark shadow around the tip of the roots. Now we've seen in some of the views already root therapy and root fillings in place. And in order to treat a patient where the nerve has died, dentists sometimes come in and remove all this necrotic tissue and replace it by root filling material, and that's what we've seen already. Now, on the right-hand side, you can just see a little shadow here. And we spoke earlier about teeth forming in a follicle of soft tissue, and if they're in a good position to come through, the follicle fuses with the mucosa and the tooth erupts without problems. Now, this tooth, like wisdom teeth often are, was not in a good place to come through. It's horizontally positioned. The follicle will have fused to the oral mucosa, but some of the follicle may have undergone cystic change. And this is a small cyst that you can see called a Dentigerous cyst related to this lower right wisdom tooth. I mentioned earlier fractures, so you can see clearly this fracture running through the right body of the mandible. But if you look for other signs, you can see the separation in the teeth and this lateral open bite. So the teeth are in occlusion, they're biting together on the right side, and they're open on the left side. Because the shape of a mandible is more than a half circle, it's more like a horseshoe, it's not uncommon to get fractures in two sides. So if you find a fracture in one place, such as this, you need to have a very careful look elsewhere to see if there is any sign of another fracture, such as a fracture of the angle of the mandible, condylar fractures, and so on. And this patient here has a left angle fracture with an occlusal step and a right, I suppose, anterior body fracture because it's distal to the canine. As we said earlier, we would normally take a second view which will show the separation at the fracture site and can sometimes reveal very clearly a fracture that might be missing or not easily seen on an OPT. So radiographs in two directions are imperative. You might have heard of a guardsman fracture. So if someone falls directly onto the point of their chin, the mechanics result in a fracture at the mandibular symphysis, and this one has been plated, but also bilateral condylar fractures. And you can see here the loss of ramus height, that's the end of the ascending ramus on the right, and superimposed on this is the condylar head, which has been displaced probably medially. And you can see this shortening. On the other side, it looks as though the condyle has been split, and that can occur sometimes. That's quite a difficult injury to treat. And again, root fillings, which we mentioned earlier. So yes, we were talking about dental abscesses, and in close-up view, a normal tooth will have a dense white line going around the roots, and this is called the lamina dura, and it's as a result of seeing in tangential view the socket in the bone around the tooth. Now, if for any reason a tooth has an infection around it, one of the early signs you see is the loss of this lamina dura. So if you follow it down on this tooth here, you see the white line here, and it stops about there and fans out, and there's a lucency around the root apex, and that is represents an infection and could be a source of upper neck swelling. This patient's got a crown on a tooth, and there's been some sort of screw put down into it in order to stabilize the crown. There has been a root filling carried out. Interestingly, the root filling doesn't get to the tip of the root, so there's probably some necrotic tissue within the residual root canal, which is prime for infection. We spoke a little while ago about teeth not being able to erupt properly and the follicular tissue expanding, and this is another example of a dentigerous cyst. So the follicle takes in fluid and expands and slowly grows and grows and can weaken the mandible, displace the inferior dental canal, which you can see running down here, and can get infected. And this is a rather large scale version of that, and it's been enough to displace the lower wisdom tooth. It's displaced the inferior dental canal right down to the lower border. We know we're dealing with benign disease because you can see this nice well-corticated outline, and you can see resorption of the roots of the second molar, and the ascending ramus, instead of having that nice curve, has now been expanded. And again, you know, this would be something that could readily get infected. At the other end of the scale are small lucencies, and there's a small lucency here, which characteristically sits behind and below the inferior dental canal. And that's called a Stafne's idiopathic bone cyst. It's not really a cyst, and it's of no great significance. It's a developmental defect on the lingual aspect of the mandible, and sometimes there can be salivary tissue within it. It's not going to change any, so if you take a radiograph this year, next year, the year after, it's not going to grow, and it's certainly not related to teeth, and it's unlikely to give rise to infection, but it won't give rise to infection. So a bit more slightly esoteric dental pathology. So this is an adenomatoid odontogenic cyst, and you can see again how it's displaced teeth, which were due to erupt. The canine tooth and the lateral incisor were due to come in here, but actually this odontogenic cyst has pushed them out of place, and it shows us this shadow in the left maxillary antrum. A little bit harder to see. You can see some spicules of calcification around this ill-defined lucency, and this is a calcifying odontogenic cyst. And the well-defined radiodense appearance of a benign osteoma. This OPG shows this haziness of the left maxillary antrum, and it probably, the pathology within probably goes right up to the orbital floor. And this is the typical sort of ground glass appearance of fibrous dysplasia. And this would be associated with a chronic facial swelling and facial asymmetry. It can encroach on the optic nerve and can threaten vision, so it is something that you need to be aware of. Now I've put this in. This is a radiograph of quite a neglected mouth. So people lose teeth for reasons of dental decay and infection, but they also lose teeth through periodontal disease and periodontal related bone loss. So this is a typical picture of a rather neglected mouth, and the bone levels supporting the teeth universally. The bone has been lost throughout the mouth. So you can see there are teeth with very little bone support, almost floating above the basal bone. And you can see areas here where the split between the two roots, the bone doesn't even cover that. So again, a site where infections can occur. we sometimes worry about patterns of bone loss, but that when there is this generalized pattern, this will reflect chronic periodontal disease. Compare and contrast it with this one, where you can see this loss of bone in the right body of the mandible, this moth-eaten appearance all around it, and potentially a pathological fracture. And this could represent osteomyelitis, it could represent osteoradionecrosis, it could represent malignancy and bone erosion. This is a more characteristic appearance of osteoradionecrosis. So you can see that this patient's had a rim resection, but you can also see that the two parts of the mandible are not in apposition. If there had been some bony union across this site, that's been lost now, and this slightly moth-eaten appearance of osteoradionecrosis and a pathological fracture. And again, the rest of the mouth, you can see quite decent bone levels around the other teeth. So temporomandibular joints and ENT sometimes cross over. You see patients with earache who've got pain from their temporomandibular joints, and we see the occasional patient with thought to have TMJ pain who's really got earache. So there's a bit of a two-way flow of patients. But you can see on this OPT, this classic appearance of osteoarthritis, lipping of the condyle anteriorly, osteophyte formation, loss of joint space, and flattening. The temporomandibular joint should be a nice rounded joint, but actually this is really very flattened. And sometimes we see things that are markers of systemic disease. So you can very occasionally recognize calcification in the carotids, which of course is going to be associated with an increased risk of cardiovascular disease. And that's sometimes picked up on a standard OPT radiograph. So the future, moving forward from OPTs, we're now moving into the generation of cone beam CT scanning. And this is very detailed CT scanning of a small volume, which is useful to us, useful to ENT, and is sometimes combined with, in one machine, with the ability to take an OPT radiograph. And this is, we're getting them in dental practices, and we're hopefully getting one here in Norwich later in the year. So this gives a very detailed view of a small volume with low dose radiation and a short acquisition time. But what's really important is it frees up the CT scanner as well for things that can only be done with spiral CT. So it will show root and antral pathology, position of teeth relative to each other and to the inferior dental nerve. And we're particularly interested in this when it comes to wisdom teeth, which often sit very close to the inferior dental nerve. But for you ENT people, it will also show mastoid pathology in some detail and the inner ear. So this is the sort of image we get depending on the direction of cut that we're provided with. And we can use it to map out the position of the inferior dental nerve. And that can be quite helpful relative to the lower third molar teeth, or in this case, it's been used for implant placement. So thank you very much for your attention. I think I've just filled my half hour.